that our recipient is sitting with the heart. And again, a grain corridor helps us to transport the heart from the airport to our hospital. And we start cutting and excising the recipient heart only when the heart is reached the hospital. We don't do that prematurely. So we have cut the aorta of the recipient, native heart, pulmonary arteries being cut. This is the IVC where we leave a cuff of RA. Because the donor IVC will always be smaller in size, what may you do? So that cuff of RA will help you to anastomose the IVC, the donor IVC with the recipient IVC. And this is the LA. So the recipient heart has been removed. And by the time that has been done, the donor heart is coming. So whenever the donor heart comes on the table, the surgeon has to examine it properly, that every structure is able to orient himself, because once the heart is flaccid, it becomes very difficult to get oriented where each and every structure is lying. So we start with the anastomosis of the left atrium, and the left atrial appendage is the landmark for the first stitch to be taken. So the anastomosis is done with a 4-row proline suture. So once the heart goes in, the anastomosis is completed in 2 layers. And once the anastomosis is complete, as we do in mitral valve, after the closure of LA, a vent is placed across the LA wall, across the mitral valve, so that the left heart is not distended by the returns from the pulmonary vein. And then we start the pulmonary artery anastomosis. The pulmonary artery will go posteriorly once the aorta and the pulmonary artery anastomosis is done, so it will be difficult to access. So this we are done with the pulmonary artery anastomosis. Then after fashioning the aorta and as per the requirement and the size of the donor and the recipient, we have completed now the aortic anastomosis. So here I was talking about the IVC. So here the donor IVC we feeling very small, so it's very important that the RA cuff is left while you excise the recipient heart. This is the IVC anastomosis, and now the only left is the SVC anastomosis. So this is the heart after coming out, and this is the hemodynamics with the arterial pressures and the PF pressures. It's very important that these patients should not have re-exploration or anything, because every small thing are going to affect the post-operative course. We don't want them to get infected. We don't want any additional transfusion or blood products or anything. And we are fortunate enough that out of 32, maybe 4 patients have received post-op transfusion for any surgical bleed, and 2 patients have undergone re-exploration. This is the post-op rehab at 1 week. The patient is going up. These are the claps that are only thing that will keep you driving for